All right, everyone. Well, thank you so much for joining us tonight. My name is Dr. D'Souza. I am going to be leading us tonight in Providence's Weight Management Treatment Option Seminar. So the purpose of this seminar is to help go over weight management treatment options that are available to kind of help build healthy habits and a good, healthy lifestyle, because this is a topic that is close to all of us. We're going to go over and meet some of our experts as well. So tonight we are joined by three really wonderful experts in weight loss treatment. We have Dr. Logan Gukin first. He is a primary care physician at Providence. He'll be talking to us about how losing even a small amount of weight can have an impact on our health, including related diseases such as diabetes, high blood pressure, and heart disease. He also will later be talking to us about some medication options for weight management, including things like GLP-1 agonists, and we'll talk a little bit more about all of that. We're also joined by Chris Collins. She is a dietitian who works with the Providence Center for Weight Management. She'll be going over the basics of a healthy lifestyle, eating habits, and effective ways to make activity a part of your daily routine. And then finally, we'll hear from Dr. Daniel Davila Bradley. He is a bariatric surgeon, the medical director of the Providence Center for Weight Management, and a foregut surgeon at the Oregon Clinic. He'll be going over surgical options for weight loss, such as gastric bypass and sleeve gastrectomy, and then the lifestyle changes and long-term care that is required after those surgeries. We'll finish the night with a little question and answer session. So during the Q&A, all of the panelists are going to try to answer as many of your questions as they can. In order to ask a question, at the bottom of your Zoom screen, you're going to see a little Q&A button. Go ahead and select that and then type in your question. And if possible, let us know who that question is for, which of our panelists here. If someone has already asked your question, you can select that question in the Q&A to upvote it, and we'll try to prioritize those questions first. Heidi Thompson, who is our weight management clinic coordinator, will be helping us to answer questions, and she may be able to put them in the Q&A as we go along. We unfortunately will not be able to answer questions about your personal medical history or any personal conditions during this seminar, so please work with your doctor and care team in order to get the answers you need after this. And remember that the information we're providing in this session is not intended as a substitute for professional medical care. So please always follow your primary healthcare provider's instructions. So first, we're going to have Dr. Gukin. He's going to kick off of our conversation by talking about what it means to have higher weight or obesity and the causes and related conditions.
All right. Thank you, Dr. D'Souza. I am Logan Gukin. I'm a primary care doctor at Providence, the Plaza on the east side here. Thank you, everyone, for coming. So we'll get right into it. This first slide, the main takeaway, I feel like, is that overweight, obesity, extremely common conditions. Defined as having excess weight. It's pretty much affects all of us in some way. So we're basically, the takeaway is you're not alone. We're not alone. Many people meet the criteria. It affects many families. Weight loss is extremely important when impacting lifestyle and health as well. So there's lots of associations with negative health conditions and outcomes. And then we do see improvement in a lot of these conditions on average with weight loss. So we'll get into that here a little bit shortly. So the first thing we want to talk about is how we define being overweight or having obesity. And this is defined by the body mass index. This has been around for quite a long time. It's sort of a calculation based on an individual's weight and height. There's lots of other tools to measure body fat. And it's one tool, but it's not always the focus of the healthcare providers, but it is at least a solid metric that we can look at. The standard definitions for overweight for most people about a BMI of 25 or greater, and obesity a BMI of 30 or greater. And obesity typically is considered a medical condition diagnosed by a healthcare provider. So now that we've defined it, let's talk about the causes and contributing factors for obesity, which are many. I think a lot of people kind of there's this rhetoric, that it's all about calories in, calories out. It's about willpower, which is just not true based on the medical evidence. There's genetic components that play a role, particularly in the way of hormones, which are natural chemicals in our body that sort of help us know when we're hungry or full, and also impact how food is utilized and stored in our body. Um, Diet itself does play a big role. I mean, we live in a society with a lot of food portions and hyperpalatable foods that result in increased caloric intake, sometimes without us really knowing or our body recognizing it. Um, Lifestyle and behavior is a big factor. Emotional eating, family, work, social obligations that can make it hard to stay consistent with diet and exercise. Our environment in general, too, our surroundings, limited access to parks, sidewalks, affordable gyms are all a factor for people. And I do think in the healthcare industry, we have to take a little bit of ownership of the many negative experience that people have had in the past trying to address their weight with healthcare providers. I think that does limit some people from pursuing talking about it with their next provider. So as you can see, generally, like we see a lot of different causes for excess weight. The more we understand the causes, the better we can treat it. It is a metabolic disease. Some causes are not within our control. Many are not within our control. And it's really not about personal willpower. In addition to the various causes, obesity associates and likely contributes to various processes. I think we're going on to the next slide here. Um, so, sorry. um, so you see having higher weight and obesity negatively affecting quality of life in multiple ways. Um, Mental health is a big component. For some, self-esteem and mood can be an issue related to their weight. The weight can limit people's physical activities and what they can do, may prevent people from pursuing new interests or doing things that they love because of constraints. Um, it may also cause certain health issues. There are strong, likely causative ties to certain conditions, particularly diabetes, sleep apnea, high blood pressure, high cholesterol. Um, when left untreated, having a higher weight in general is often associated with many serious health conditions outside the ones listed above: heart disease, stroke, arthritis, liver disease, gallbladder disease, and many different types of cancer. So, in closing, it's a huge topic. For many of us, a personal topic, but also from a public health standpoint. Um, Very multifaceted, so management is often very personalized. Um, it's great that everyone took the steps to be here today to learn more about the options. Um, many things that we'll talk about here moving forward. Get to them shortly.
Thank you so much, Dr. Gukin. We really look forward to hearing more from you later in the seminar. I want to take a chance now for us all to pause for a little moment of reflection. As Dr. Gukin said, it's very important. We've all taken a big step by being here today. I want you to think about what having a healthy weight means to you. Why is it important to you? And how it could impact your life and health overall. So think about that. Write down any physical, emotional, social aspects of your life that might, come to mind or could change. And think about that as we move forward with the seminar. So next, we're going to hear from registered dietitian Chris Collins. She's going to share lifestyle changes that you can make as part of a weight loss plan, including nutrition and exercise tips.
Thank you, Dr. D'Souza. My name is Chris Collins, and I am a registered dietitian at the Providence Center for Weight Management. I'm also a certified specialist in obesity and weight management. If you've never had the pleasure of working with a dietitian, a registered dietitian or a registered dietitian nutritionist is a credentialed healthcare professional with expertise in food and nutrition and medical nutrition therapy. Dietitians can help you create a lifestyle treatment plan to improve your health and support your weight management goals. Weight management does start with lifestyle, like nutrition and eating behaviors and physical activity, and the best lifestyle treatment plan will be customized to you. It'll depend on your personal daily habits, your food preferences, your medical history, and other health factors. Before we talk about lifestyle, I want to acknowledge that many of you have told yourself, or maybe somebody else has told you, that if you just eat less and move more, you'll lose more weight. Well, as we heard from Dr. Gukin, there are many other factors involved, and it's not as simple as calories in and calories out. So if you feel you've made every effort to improve your diet and your exercise habits, and you're not losing weight, do have a conversation with your doctor. So let's talk about some opportunities. I love that word, opportunities, to improve some of our eating habits. And we're going to start off with calories. Calories actually do matter. If we're eating significantly more calories than we expend through metabolism and activity, we're likely going to gain some weight. A gentle calorie reduction of about 250 to maybe 500 calories per day would be a good start. Consider your portions. If you leave the table very full or even stuffed, your portions might be a little bit too large for you. So simply shifting to smaller plates or bowls can help reduce your portion sizes and maybe reduce your calories. Eating patterns. Eating at regular intervals and avoiding meal skipping or maybe long gaps between meals helps keep your blood sugars regulated and can prevent excessive hunger. Being overly hungry makes us vulnerable to choosing high-calorie foods and overeating them. So you can start simple by eating 3 structured meals a day, maybe about 3 to 4 hours apart. If you're eating most of your calories at the end of your day, think about cutting your dinner portions in half and maybe just shifting those calories to earlier in the day. Eating in this way makes us more fuel efficient. Meal planning. When I say meal planning or menu planning or meal prepping, my patients roll their eyes to the backs of their heads. It seems like such a huge task, a big undertaking, but it's really not. It doesn't have to be. Just think about the week ahead, or maybe even just 3 days ahead. What are your blocks of times to shop and cook? Take advantage of those times. Think about a few meals that you can make that might carry you a few days. And when you're making those meals, make a little extra to take for lunches. You really can't start small. You maybe just with one meal consistently. So it doesn't have to be a situation where you're planning and prepping every single bite for every single day. It doesn't have to be that structured. Mindful eating. So mindful eating is the practice of paying attention to our hunger and our fullness signals, and eating without self-judgment or criticism. One of the best ways that we can implement right away is to eat more slowly. Eliminate distractions. Try not to multitask when we're eating. I know we all do it. Be present in the moment. When we eat, all the flavor and all the enjoyment from food comes when you're chewing, right? If that food is tasting really good, it's a party in your mouth. And once you swallow, party's over. So take some time, spend a little time with that food and savor it and enjoy it. So many of my patients that work on the skill of eating more slowly come back to me and report that they actually fill up on less food. And that's because eating more slowly allows time for your stomach to talk to your brain and let your brain know that it's being stretched. And this is how we know that we're starting to feel fullness. So eating more slowly can effectively be a way to reduce calories and lose weight. Food quality. What you choose to eat does matter. Choose fresh foods, minimally processed foods whenever you can, and try to cut back on some of those highly processed foods and restaurant foods. Food processing methods and chemicals and preservatives in foods do have a link to overweight and obesity. Not to mention processed foods and restaurant foods are often higher in salt and sugar and fat and of course calories. So try to minimize your exposure to processed foods and restaurant foods as much as possible. Try to choose foods that come from a farm or a plant and eat fewer foods that are made in a plant. There's many ways to make improvements in our eating habits, and there is no one diet plan that is superior for weight loss. Really, the best plan is one that's medically safe for you and one that you'll stick to. Let's talk about physical activity. So just to say it simply, physical activity is simply moving your body, and regular physical activity is the greatest predictor of weight loss maintenance. Here's one really cool factor. Physical activity, independent of weight loss, has a positive effect on reducing visceral fat, which is that dangerous fat that's deep in our organs and causes a lot of health issues. So if you start an exercise program and you don't even lose a single pound, you're really doing a positive thing for your health. So start where you can. Make it part of your routine. Try to find ways to add steps to your day. Take walking breaks at work or walk the dog. Use stairs instead of the elevator. Walk while waiting or while your kids are playing soccer or at soccer practice. Take a few laps around the field. Walk laps in a store. If you go into Costco, that's a huge store. Take a big lap around the perimeter before you grab a cart and walk up and down the aisles. For every 30 minutes of sitting, I recommend trying to get up and move or even get up and stretch for 3 minutes. It really makes a difference. Try to make time for purposeful activity or what we might call exercise. You can exercise for longer blocks of time or even in small bouts. They're both effective. If you don't have 30 minutes to exercise, how about 10 minutes 3 times a day? Other ways to work in exercise could be to ditch the car, grab your bike, or go for a walk to your destination. You can even build strength workouts into your daily routine. I have been known to do lunges and squats while blow drying my hair. So where there's a will, there's a way. Make an exercise appointment with yourself and prioritize it like you would a doctor's appointment or a tea time or a hair appointment. Again, look for opportunities to make moving your body part of your daily routine. I know that we can all find those opportunities. Providence offers a variety of support services that will help you with your weight management goals. We offer wellness and exercise classes that include Base Camp and the Milwaukee Teaching Kitchen and the Diabetes Prevention Program, which is a lifestyle program for those who are diagnosed with prediabetes. There's also behavioral health services and programs such as weight management education, stress management, nutrition support and dietitian services, and eating disorder specialists. There's some other tools that you have access to right now. Those include free meal tracking apps. MyFitnessPal is kind of a long-standing favorite. Verytastic is a meal tracking app that we use here in the surgery clinic. And there's other apps like Lose It and many others that are free and available to you. Step counting devices and watch devices and Fitbit devices can really make incorporating activity fun. I know if you have an Apple Watch, you can close those rings. I know you can do it. So get those things out and see if they can help motivate you to have fun with your movement. An important thing to know is that while weight loss can improve your overall health, restrictive dieting can increase risks for disordered eating, which is abnormal eating patterns and distorted attitudes towards food and weight and shape and appearance. Talk with your doctor before starting a weight loss program if you're concerned you may be at risk for these things. So what can you do? Start by talking with your doctor if you're interested in creating a lifestyle plan that will work best for you. Your doctor can provide advice and assistance and resources to help you. Ask your primary care provider for a referral to a dietitian. We would love to help you. The strongest predictor of weight loss with lifestyle changes is sticking to it. So work with your support team and choose a realistic plan. So important to get off to a good, strong start. Any steps that you can take are going to be beneficial, so you can start small. Even weight loss as little as 5 to 10% has a real positive impact on your blood sugars, your blood pressure, blood fats, liver health, and so much more. So look for those opportunities to make little changes in your lifestyle habits that can have a big impact on your health. Thank you.
Thank you so much, Chris. And everyone watching, remember this seminar is being recorded. So if you didn't write down all the resources that Chris shared, don't worry, they will be in the recording. Let's take some time while it's at the top of our minds to think about all of these great tips that Chris has shared. So think about or try to write down 2 or 3 of those tips that you think will be most helpful for your lifestyle management and why they appeal to you. So take some time, think about it, and kind of write them all down. All right, we'll now turn back to Dr. Gukin. He's going to share with us more about medical weight management, including the medications that are kind of all over social media now, Ozempic, Wegovy, Zepbound, and Mounjaro.
All right, thank you. Yeah, let's talk about the topic on a lot of people's minds these days, I think, the medicine options. So we've got quite a few things. Obviously, a lot of times it's best to start with the lifestyle changes. People are the most successful if they're using medications in the context of lifestyle changes. But if the lifestyle changes alone are not working well enough, it may be time for a doctor-supported or medication-supported treatment plan. So the treatment plan can look a lot of ways. You should consider it if you have a diagnosis of type 2 diabetes, body mass index of over 30, or a body mass index of over 27 with some of the associated conditions that we see, which would be things like high blood pressure, high cholesterol, type 2 diabetes or prediabetes, and fatty liver disease. So again, the goal is to be healthy. Medications combined with diet and activity help people lose weight quite a bit more than one or the other alone. So looking at some of the newer medications here, we've got semaglutides and tirzepatide. They work in similar ways. Tirzepatide has a little bit of an extra component to it. These are falling under the umbrella of GLP-1 agonist medications. So semaglutide, Ozempic, and Wegovy. Ozempic's probably the most famous. That jingle gets stuck in our head. Lots of benefits. So weight reduction on the order of 10 to 20% for most people. Reducing the risk of heart disease, reducing complications for those who have kidney disease, improving functions and outcomes for people with obesity and heart failure, helping to reduce fat and inflammation content in the liver. They do have some downsides, generally very safe medicines, but GI side effects, digestive side effects are very common, probably on the order of 20 to 30% in my experience. Most commonly what I see is, things like indigestion, heartburn, feeling very full after meals. You can also see diarrhea, constipation sort of symptoms, and abdominal discomfort. So the tirzepatide group, that's Zepbound and Mounjaro, they have very similar ways that they work, and they ultimately do have very similar side effect profiles and things that they help with. In addition to the ones we already talked about, sleep apnea, weight reduction will often not always, but often reverse or improve sleep apnea. They can help lower blood pressure, help with diabetes. And then there's kind of ongoing studies about the heart and the kidney benefits, but it seems promising. We'll see how it comes out. Again, the cons, GI side effects are common. With the semaglutide group, there is one oral medication. The tirzepatide group is all injectables, most of which are once a week. There are other medication options. They've been used for a long time. Many of them were designed for different things, actually. But ultimately, most of them, what they do is they suppress appetite in the brain. Wellbutrin or bupropion is a very common one. Naltrexone as well, topiramate or Topamax. Phentermine is predominantly just an appetite suppressant. This was designed specifically for this reason. And orlistat is now over the counter, which works in its own way by limiting fat absorption in the gut. These medications, on average, most of them provide roughly 5 to 10% weight loss. Some of them are used together, but they're not quite as effective as the semaglutide or the tirzepatide groups. Sort of a side note on medications, some medications that you may be on can cause weight gain or limit people's ability to lose weight. Probably the most notorious of these would be mental health medications. So SSRIs like Prozac, SNRIs like Cymbalta, antipsychotic medicines like risperidone, steroids, especially long-term use. They're not used as much anymore as they used to, but we still do see it. And then birth control, contraceptive methods, anything that is hormonal can sometimes affect your weight. So your doctor may end up tweaking some of those medicines, but I wouldn't recommend doing it on your own before seeing them. They may sort of come up with a way to try to maximize your weight loss without affecting your other conditions that you're taking your other meds for. So again, the first step is to come in and see your provider and discuss your options. You can work on a tailored plan for your weight loss goals with your provider.
Thank you again so much, Dr. Gukin. So everyone, remember that your primary care physician can help you create a treatment plan for medical weight management. We've just heard about it with Dr. Gukin. And just another note, not all insurance providers will cover all of the options that Dr. Gukin discussed. So talk with your primary care, and also you can reach out to your insurance provider themselves and see what's covered in your plan. Before we go on to the next session, I just want to give a quick little reminder about our Q&A session and that Q&A button that is at the bottom of your Zoom screen. So go ahead and click that, type in any questions that you currently have, and we will answer them after we hear from our next expert, Dr. Davila Bradley. He's going to talk about surgical options for weight loss, including who might be a candidate for surgery and what recovery and necessary lifestyle changes look like afterward.
Thank you so much, and thank you for the opportunity to be here and share our experience with all of you. I hope this is very helpful and it helps you understand the management of obesity better and the treatments that are available. I think all these treatments that we're reviewing tonight, they work in conjunction. There's no like a specific order. There's no specific a need for do one or the other. I think our philosophy is that weight management requires multidisciplinary management, and that includes lifestyle modifications, diet, medication, surgery, all of them in conjunction, and not all of them together or at the same time, right? Like there's a time and place for each of these treatments. So let's talk about the surgical options. And again, these surgical options are a tool to add. It's part of the armamentarium we have for the treatment of obesity. So candidates for weight loss surgery are patients whose BMI is 35 or over. This is different for Asian populations with the requirement is BMI 27.5 or higher. If your BMI is between 30 and 35, and there is another condition that might make you a candidate too. These conditions are usually things like type 2 diabetes, high blood pressure, sleep apnea, high cholesterol, among others. And it's important to understand the surgery and risk and understand the other options that you may have tried in the past and you might have been successful, or sometimes we see weight regain with other strategies. So this is, again, one more tool we have, other than diets and other options that are out there. These BMI guidelines that we're discussing tonight, these are relatively new as of 2022. So it's taking some time for all insurance companies to adapt the new guidelines. The traditional guidelines were considered BMI 40 or higher, or 35 to 40 if there was a comorbidity. That number has dropped to the current guidelines, which is 35 or higher for any patient, or 30 to 35 with comorbidities. But it's taking some time to the insurance companies. We have made some progress, but it's important to review your personal coverage. There are patients who might not be great candidates if there's an active drug or alcohol problem, not a history of, but if it's unresolved, that might not make you a candidate. If there's any uncontrolled psychological conditions, pregnancy is important to understand that if you're planning to become pregnant in the next 18 months, it's better to consider the other options and not surgery. Or if you're, of course, not healthy enough for anesthesia, general anesthesia, or the surgical procedure. So the first procedure we're going to discuss tonight is the gastric bypass. You might have heard of the gastric bypass in the past. Is the most standard traditional surgery that is out there, and it's a great operation. I think it's important to understand who is the best patient for it. So the way we do a gastric bypass, the surgeries are done with laparoscopy or robotic surgery, which means small incisions, and that helps with faster recovery and less pain. The way we do a gastric bypass is by rerouting the way food goes into the small bowel. So what we do is we cut the stomach into a small pouch. This pouch is about the size of a golf ball or a hard-boiled egg. And that's pretty much like how much food you can eat after a bypass, right? We divide the bowel downstream and we bring it up and we connect it to that pouch. Therefore, the larger part of the stomach that is there, we leave in place, is still producing the gastric juice and the acid, and that's traveling down on the first portion of the bowel that is now not receiving any food. So this bowel is connected downstream, and the reason patients lose weight with this procedure is because of the restriction of food, that how much you can eat because of the size of the pouch, but also some degree of malabsorption because of the rerouting of the bowel. The surgery takes about 2 to 3 hours. Usually patients stay in the hospital for 1 or 2 days. It's normal to feel weak and tired for a few weeks afterwards, and we recommend avoiding strenuous exercise for the first few weeks, but we encourage everyone to stay active as much as possible within certain boundaries. The benefits of this operation is that patients feel less hungry. They feel full after eating less food, and it helps significantly with needing less blood pressure medications or diabetes medication. This is one of the operations that works the best for diabetes, depending on how severe your diabetes might be. And it's more likely to help with 60 to 80% of the excess weight in the first 12 to 18 months. It also reduces the risk of heartburn. So we use it on patients who have very severe reflux disease or large hiatal hernias. The next operation we're going to discuss is the sleeve gastrectomy. The sleeve gastrectomy is a surgery that has become very popular in the last decade. Over the last 15 years, it's become the predominant surgery performed in the United States. The sleeve gastrectomy is also performed laparoscopically through small incisions. In this operation, we are not rerouting the bowels. What we are doing is we are transecting or dividing the stomach, and there's a large portion of the stomach that we're going to remove. The final result is a very narrow stomach. I tell my patients it looks like a banana. Imagine that the width of that stomach is the width of your finger. So it really limits the amount of food that you can eat. So we're removing about 75, 80% of the stomach. It takes about 1 to 2 hours. Patients stay one night in the hospital. Some patients are able to go home even the same day. The recovery is very similar to the gastric bypass, and the postoperative care is very similar. And it also helps feeling less hungry. and being able to eat less food. It also helps with blood pressure and diabetes. Especially for early diabetes, we have seen really good success with the sleeve as well as the bypass. The weight loss is a little bit less than the bypass, but actually pretty good. In average, most patients will lose 60-70% of the excess weight. The ballpark I tell patients is the difference between a sleeve and bypass is about 10-15 pounds on the long term. So it's pretty good, pretty much almost as good as the bypass. And it has, it's a little bit safer, although the bypass is still very safe, but there is less risk of dumping syndrome. Dumping syndrome is something that happens when you eat food. In the gastric bypass, when the food, especially sugar or carbohydrates, when they get into the bowel doesn't like that. It might give you a uncomfortable diarrhea and make you feel very sick. It can crash your blood sugar, and then you need to take a 6-hour nap. Dumping can happen with the sleeve, but it's less common. Is more common with the bypass. With the sleeve, some patients can develop heartburn. It's not extremely common, but it does happen. Most of the time, we're able to manage that with medications. There are other procedures that are less common, like gastric bands, balloons, adrenal switch, or revisional procedures. We think that the sleeve and the bypass are the most effective procedures and the safest procedure, and that's why those are the ones that we perform. We do take care of patients with gastric bands. Some of the options we give for patients with a gastric band is management, and meaning adjustment of the band. But quite often, patients request the band to be removed and revision to other procedures like gastric bypass or a sleeve. So considerations for weight loss surgery is important to understand the risks and benefits. So we're extremely cautious. We take every precaution when it comes to patient safety. But there are certain risks that we'll discuss specifically when we are seeing every patient, and we are able to use calculators that determine the specific risk for an individual patient. It's important to know that lifestyle changes are going to be a significant part of the success of patients who have surgery. Without lifestyle changes, that can affect the performance of the surgery. And short term, it might take a couple of weeks for patients to go back to normal activities. It's important to avoid heavy lifting or long travel, avoid alcohol for at least a year, and before trying to get pregnant for 12 to 24 months to decrease the risk of a miscarriage. In the long term, it's important to continue monitoring what you eat and your weight, planning healthy meals, and taking the vitamins and mineral supplements that we recommend, staying hydrated, exercising regularly, and visiting the surgical team to make sure that everything is working in order. And we're going to be checking your vitamin levels and supplements and everything that you need. There are more routine visits in the first year and then at least yearly thereafter, and will be available in between appointments as well. So if you're interested in these options, talk to your primary care provider. They can guide you to the program, and we can determine if you're a good candidate for surgery. And we'll review with your insurance company what the exact coverage is.
Thank you so much, Dr. Davila Bradley. So we've now heard from all of our panelists. It's going to be time for us to open things up to questions. So if you haven't yet, here's a chance. Type in your questions into the Q&A section. And while the last of you are kind of doing some of that, let's recap what we've learned so far. So Dr. Gukin started by talking about the causes and related conditions of overweight and obesity. And he also explored some of the medical weight management options that we currently have. Chris Collins, our dietitian, covered the basics of nutrition and the importance of staying active. And Dr. Davila Bradley went over when we consider surgery, outlining the most common procedures that we do, and then walking through some of the after surgery lifestyle changes. So we'll kind of look at the questions now, try to go over them as much as we can. So in looking at these questions, the first one that I have is actually for Chris. So Hannah wants to know, is intermittent fasting something that can be helpful in losing weight and maintaining a healthy weight long term?
Thanks for your question, Hannah. Boy, this is something that's been popular in social media, right? Intermittent fasting. So when we look at the research in terms of calorie intake on an intermittent fasting schedule and those of just kind of standard reduced calorie dieting, they turn out to be about the same. So there really isn't any significant benefit in intermittent fasting. But having said that, remember, I was saying earlier that the best plan is the one that works best for you and one you can stick to. So for some people, intermittent fasting can be helpful because you're not having to count calories, you're just eating more on a schedule. So if that's a strategy that might work best for you, I would recommend getting some help with a dietitian, from a dietitian, to help you build that program that is best for you. I would say also, for those of you that might be diabetic or on anti-diabetic medications, you need to be really careful about participating in intermittent fasting. So do keep that in mind.
Thank you, Chris. The next question, I actually might be able to answer this. This question comes as, do you have to try any weight loss medications before considering surgery? So my caveat is I'm a surgeon who works with Dr. Davila Bradley as well. You don't necessarily have to have tried a weight loss medication before considering whether you're a candidate for surgery. But what we do like to see on the surgery side is that you have tried some form of weight loss, whether that be diet, exercise, you're working with your primary care provider and doing those things to help to lose weight beforehand, considering that surgery is a more advanced step to weight loss. Now, you may have lost a bunch of weight with diet and exercise and then regain and really struggling. That might be a good time to talk to your primary care about considering surgery. And medications may help with some of that, but they aren't mandatory in order to be considered for weight loss surgery. So talk to your primary care and work with them. The next question we have is for Dr. Davila Bradley. How do you decide which surgery is best for someone?
That's a great question, and I can talk for hours and hours about that. And actually, I did today with another presentation with the team, talking about sleep versus bypass and which one is better. And I'm not going to talk for 2 hours about this. I'm going to try to keep it short. But what I think is not about which one is better, is about which one is optimal for you and what do you get out of it. In general, my saying is that the best operation is the one that you choose. But I think the real benefit of a gastric bypass is for patients who have severe reflux disease or really bad hiatal hernias, or patients who have significant diabetes. Those patients who have had diabetes for 3, 4, 5 years and they're maybe on insulin and they're struggling to keep the A1C under control. Those are the best candidates for a bypass. Because the bypass does have a little bit more risk on the immediate after the surgery procedure, but also long term. We see more problems down the road with the bypass, and it's not like we see a lot of them, but we can see things like internal hernias, ulcers, bowel obstructions. So the sleep in general is safer. So if you don't have diabetes, you don't have significant reflux disease, we're going to be checking to see if you have a significant hiatal hernia. I think the sleep is more optimal. Because your long-term risk is lower, your short-term risk is lower, your weight loss is almost as good by 10 pounds in general. So I think that's why I think the sleep will be a great option for someone who doesn't have significant diabetes or significant reflux disease. That's my short answer.
I muted myself, sorry. This question is for Dr. Gukin. Do all PCPs prescribe weight loss medication or do only certain PCPs?
It's a great question. In theory, we all can do it. I think there's probably a few factors at play into why someone might not do it. I guess first of all, I should say, in my experience, the vast majority do prescribe them. At least the ones that I've worked with and talked with through Providence. And then when I was in residency as well, it was like starting to gain a lot of traction, and we were all really excited about it. But I think initially people got discouraged by the insurance coverage, because that's just how it happened. Like it's usually delayed for almost every new medication, no matter what what condition we're talking about. It's almost always delayed, because insurance just takes a little while to adopt the changes. And I think a lot of people initially were not getting anything covered, so I could see that playing a factor. Second, primary care are generalists. I think comfort level sometimes is a little bit delayed. The specialists are specialists, so that they're focusing. So if you have a weight loss specialist or potentially an endocrinologist, they may have adopted it earlier. And then three, I think education too. Medical education has changed significantly in regards to obesity. It's basically gone from being something treated as a disorder of willpower to more of a medical disorder, medical disease, metabolic disease. So I think the younger generation maybe is potentially more willing to take that dive. But we also, I've been practicing for 4 years. We kind of had that built in to our training as well. We were using it for diabetes. It started being used for weight. So we've had, the newer doctors in the last 5 to 10 years, I think, have just had a level of comfort with it as sort of a normal thing too. So.
And on the topic of medications, Dr. Gukin, Robin has a question about how these weight loss medications may help with intracranial hypertension that can be associated with obesity. Is there any evidence to support that?
This is a cool question. I didn't know anything about this until doing a little of prep for this preparation, because I haven't run into this scenario, but the evidence suggests yes, that it will improve IIH, intracranial hypertension symptoms, and the hypertension itself, probably from a couple different mechanisms. It sounds like the weight loss itself probably improves it, but also the GLP-1 component in the brain, it may actually reduce the production of cerebrospinal fluid, which is one of the drivers of IIH. So very good question. It seems like the research is kind of early, but it's pretty promising. So I don't know. It'd be interested to see. They're starting to use these medicines for things that are not, like we're using them, some of them for like heart failure, even if someone doesn't have obesity. So I wouldn't be surprised if some of these things start coming out of the woodwork, like maybe treatment just for IIH down the line. We'll see. But there's lots of research to be done.
Yeah, that's wicked cool that we can use some of these medications for multiple different things.
Yeah.
I have 2 questions for Dr. Davila Bradley, and they kind of go hand in hand. One is, what kind of support is available after surgery? And the other one that is a little bit related is, what does the data show about relapsing weight gain with bypass versus the sleeve, and in terms of amount of weight and time frame? So I think that relates a lot to the support after surgery.
Right, and those are great questions, and I should have done a minute of dedicating to that question, that second question. The first question, the support after surgery, we're here for you. We have a great team, and I tell my patients, surgery is very important, but surgery is just this little bit, and working with the rest of the team after surgery is going to be what's going to make you very successful. So you have, for the first year, many appointments with everyone in the team, and then as you are progressing, you'll see us at least every year, but more if you need to, right? So there's a lot of work to be done after surgery. That's actually when the hard work starts. So we have a fantastic team to help you with that. The question about weight gain after bypass and sleeve, that's a really good question. So the data so far shows that most of the weight happens in the first year or two, and there's a plateau. There might be a little bit of weight regain. Regaining all of it is very rare, and when it happens, is mostly associated to dietary habits. So what I was saying earlier about the difference between sleeve and bypass, that gap of about 10-15 pounds between sleeve and bypass, that stays true over time. When we look at data for 5, 10, 15 years, that same gap exists. For example, if a patient is down 100 pounds with a bypass 2 years after surgery, and the same patient, but they have a sleeve, is down 90 pounds, that gap persists over time. So even if they regain a little bit or lose a little bit more, they usually stay within those 10 pounds. So there's some perception that patients with a sleeve will regain all of it after a few years. That's not true. We have seen really good success long-term with a sleeve, and so with the bypass. So the difference, 10-15 pounds and a little bit of weight regain after a year or two, but limited, and the gap between sleeve and bypass persists over time.
Thank you. And then Dr. Gukin, I have 2 questions for you about the weight loss medications. The first is, what is the evidence for success with the oral GLP-1 meds as opposed to the injectable ones? And then the second is regarding the medications, what does weight regain look like when you go off of them? And so then maybe how long should you be on those medicines?
Great questions. The oral GLP-1 meds, it seems like there's a little bit of conflicting data on it, but they do provide some weight loss. I've seen quotes anywhere from like maybe 5% to 17 to 20% of weight loss, which is kind of the Ozempic, Wegovy range is thought to be probably like 10 to 20, 12 to 20%, something like that, over time. So probably close. We do see definite differences across individuals in how things are absorbed and processed through the liver. So that could play a role too. And it might be sort of something that needs to be individualized. But it seems like there is decent evidence that it results in similar, if slightly less, weight loss potentially. And the second question, is there typically weight regain when you go off the medicine? This is an interesting one because I haven't had any patients who have gone off of them yet, because we're either using them for diabetes, long-term management, or they're working and we're not going to do it. This was a big initial question with these medications. And I think Dr. Davila Bradley has insight into this too. We're kind of trying to figure out the role of the medicines in regards to the longevity, and like again also with like post-bariatric surgery. It seems though like people probably benefit from them long term, and that the weight gain probably does come back, which is going to be extremely variable for people how quickly. I think probably the people who have been successful in implementing significant lifestyle changes are more successful too in keeping it off. But yeah, it seems like the weight probably comes back. How much over what time period is really variable for people, from what I've gathered. And it seems like I kind of think maybe it'll be used sort of like maybe like statin medications. I mean, it's associated with all these, those are for cholesterol lowering. It's associated with all these downstream health benefits. And so I wouldn't be surprised if it's used sort of as a preventative measure long term, for weight management. It looks like Chris maybe has some wants to throw some insight into this one too.
Yeah, if you don't mind. So when I talk to patients about weight regain after stopping these medications, I kind of explain it like the Ozempic and the tirzepatide medications, they're like kind of like hormone replacement therapy. Think of it that way. I mean, the GLP-1 or the incretin hormone that your gut is making, that's what you're deficient in, or it's not working so well. So that's actually what Ozempic and Mounjaro and Zepbound, that's what they are. It's replacing those hormones or making them more effective in your body. So just like any hormone or high blood pressure medication you take that's helping to correct the dysfunction, once you stop taking it, the dysfunction is still there. So think of it that way, that yes, some medications are going to be, you might be able to reduce them and still maintain a healthy weight. But if you stop the treatment, the weight is likely to come back to some degree.
I think that's really where having kind of we call it a multidisciplinary team. So it means having your primary care provider, your dietitian, in some cases your surgeon, kind of all working together when we talk about weight. I mean, 70% of the United States population has some degree of being overweight or obese at some point in their life. So this is everywhere. So I think that's where it's really helpful, kind of having a whole big team like we have at Providence to be able to work together. That's really all the time that we have for the Q&A. I really appreciate all of the questions that you all have put in. Thank you so much to everyone who has come and to spend an evening talking with us, letting us know what your thoughts are, and hearing out kind of some of these options for you. And I really want to give a big thank you to our expert panelists for sharing all of their wonderful knowledge. So if any of you would like more information about nutrition services, primary care services, meeting somebody great like Dr. Gukin, or bariatric surgery, then call any of the numbers listed on the screen, or you can visit www.providence.org/bariatrics, and there'll be additional resources provided there to help find some services near you. So another reminder that the recording is going to be sent out to everyone who participated tonight. So anything that you didn't get a chance to take notes on, it's all going to be right there. So thank you again so much for a really lovely evening. I hope you all have a great rest of your night.